Hello everyone. The topic we are covering today is diabetic ketoacidosis. So, diabetic ketoacidosis. In this, the main thing we have to understand first is the pathogenesis, how the condition develops. So, first thing that this person should have is insulin deficiency. Now, it is seen in both type 1 as well as in type 2 DM. In type 1, it is absolute deficiency. In type 2, it is relative deficiency, but it is a deficiency state. What will happen in a deficiency state? In a deficiency state, your body tissues, specifically muscle and fat, which are insulin dependent, they won't be able to take up the glucose inside them. Okay, so it's an insulin deficiency state. We know in type 1 it is absolute, in type 2 it is relative, and in this condition, when there is insulin deficiency, muscle and fat, which are insulin dependent tissues, they will not be able to take up the glucose inside them. As a result, there will be increased circulating glucose levels in the blood. Also, your liver will start producing glucose. Your liver will start producing glucose, and that will also result in hyperglycemia. So, how liver gives glucose? Two mechanism. I'll write in short: GN, gluconeogenesis, and glycogenolysis. So by breaking down the glycogen and by producing glucose from non-glucose molecules, liver starts producing glucose, and that also gets dumped into the blood, resulting into hyperglycemia state. Now, so your body has less amount of insulin at this present time. Okay, now you develop a stressful situation, like you are having some infection or some illness. Okay, so some infection or some illness will give you stress. So second problem is now stress. First is insulin deficiency, and second is stress. What this stress will do? Insulin is an anabolic hormone. Okay, now in stress you will start producing more of a catabolic hormones. What are the catabolic hormones that you have? Glucagon, I write it in short: glucagon, cortisol, catecholamines, and growth hormone. These catabolic hormones, growth hormone, catecholamines, cortisol, glucagon, they will act exactly opposite of insulin. What insulin does? Insulin is an anabolic hormone, so it will produce protein, it will produce lipids. Okay, but these catabolic hormones, they will break down the lipid, they will break down the protein. So there will be proteolysis, there will be lipolysis. These hormones will cause lipid breakdown, protein breakdown, proteolysis, lipolysis, and as a result you will have a lot of free fatty acids. Now these free fatty acids, they go into the liver. In the liver, okay, there are hepatocytes. Inside the hepatocyte there is mitochondria. Inside the mitochondria of hepatocyte, this free fatty acid will get converted into ketone body. Where ketone body formation takes place? It takes place inside the mitochondria of hepatocytes. This is the site of ketone body formation. Now, how does ketone body formation takes place? So what happens is, this free fatty acid will be broken down into acetyl CoA, which is the ultimate product within the mitochondria, and then two molecules of acetyl CoA will unite together and will form acetyl CoA. So two molecules of acetyl CoA will unite and form acetyl CoA. And this step is done by the enzyme thiolase. Okay, but just to know that two molecules of acetyl CoA, they combine and form this acetyl CoA, which is done by the enzyme thiolase. Okay, next what will happen to this acetyl CoA? HMG CoA formation will take place from this HMG CoA. How it forms? Another acetyl CoA molecules, another acetyl coenzyme molecule unite to this acetyl CoA and form this HMG CoA. The full form is hydroxy methyl glutaryl coenzyme. Hydroxy methyl glutaryl coenzyme A. Complete name is beta hydroxy beta methyl glutaryl CoA. So it is beta hydroxy beta methyl glutaryl coenzyme A, and the step is done by HMG CoA synthetase, which is the rate limiting enzyme of this reaction. For ketogenesis, the rate limiting enzyme is the enzyme which forms the beta hydroxy beta methyl glutaryl CoA, that is HMG CoA synthase. Okay, this is the rate limiting step. And then from this HMG CoA we will have our first ketone body, that is acetoacetate. How? By HMG CoA lyase. HMG CoA lyase will break this HMG CoA and will liberate one molecule of acetyl CoA and will give you acetoacetate. Then from this other ketone bodies will get produced. This acetoacetate will be reduced to form beta hydroxy butyrate. I'll write in short BHB. This acetoacetate will get reduced to form the major ketone body of your body, beta hydroxy butyrate, and it will be spontaneously decarboxylated. So CO2 will be liberated from it and will produce acetone. So these three are your ketone bodies. Number 1 acetoacetate, number 2 beta hydroxy butyrate, and number 3 acetone. Acetone is spontaneously produced. Major ketone body, MKB, short में लिख दिया. Major ketone body is beta hydroxy butyrate. So this is your ketosis. This is your ketogenesis. This is the process known as ketogenesis. Now what is ketosis and what is ketoacidosis? Ketosis is elevated levels of ketone body in your blood. That is ketosis. And when the accumulation in the blood is dangerously high, it is extremely high, this is known as ketoacidosis. So in decay, your ketoacidosis concept is clear. Now in decay also you have dehydration. You also have lot of dehydration in ketoacidosis. That is why you have to give lot of fluids in this patient. Why there is dehydration in this patient? See, a lot of glucose is getting excreted by the kidney because it crosses the renal threshold. What is the renal threshold for glucose? What is the threshold? Remember, if you don't remember, I'll write it. It is 180 mg per dl. So glucose is how glucose is excreted. Glucose is freely removed by filter. Clear it. So glucose, what happens about filtration? Okay, glucose is freely filtered at the glomerulus. So everything comes in the proximal convoluted tubule. Glucose is freely filtered at the glomerulus and everything comes in the PCT. Next, what will happen? Reabsorption in the PCT. In the PCT, glucose is reabsorbed by SGLT2 and SGLT1, sodium glucose cotransporter 1 and 2. Now, when the plasma glucose level reach more than 180 mg per dl, these transporters, they get saturated and this excess glucose appears in the urine, that is known as glucosuria. Okay. And I think another important term which is related to this, first, renal threshold for glucose. Renal threshold for glucose, this is the first term. Another important term that is related to this is the TM, transport maximum for glucose. So what is transport maximum for glucose? See, it is written as mg per minute. So how much glucose in mg can be reabsorbed by the renal tubules per minute is transport maximum for glucose. It is 375 mg. So what is the renal threshold? It is the blood levels of glucose. Renal threshold is the blood levels of glucose. So it is a blood level. Above this blood level, blood urine में glucose आ जाएगा. Above this blood level, glucose will come in the urine. And what is transport maximum of glucose? It is the amount of glucose that is reabsorbed from the renal tubules. So this is not blood. This is from the renal tubules. The maximum amount of blood, that maximum amount of glucose that can be reabsorbed per minute from the tubules. That is threshold maximum. That is 375 mg per minute. If I ask you a question, right, related question, what are the examples of SGLT2 inhibitors? SGLT2 inhibitors, you know, right? So they are gliflozins. Gliflozin. Okay. First example was your canagliflozin. Sorry, DAPA. First one was DAPA. Then came Cana. Then we have EMPA. Then we have ER2. These four are there: DAPA, gliflozin, Cana, gliflozin, EMPA, gliflozin, and ER2, gliflozin. How they work? They block the SGLT2 inhibitor. They block the SGLT2 receptor transporter in the PCT, and this results in glucose in your urine. So as a result, the blood glucose levels fall. So they result in glycosuria. Okay, they will result in glycosuria. Their use is not just limited to type 2 DM, but they are getting also used in CKD. So they are said that in CKD they slow down the progression of nephropathy. They slow down the progression of nephropathy. In CKD they are getting used. So we all know that type 2 DM patients are at higher risk of developing CKD. So there are two conditions that causes CKD. One is your type 2 DM, other one is your hypertension. So in many of the patients you will find them together, type 2 DM and HTN. So what will give to these HTN patients as well as type 2 DM patients to prevent the renal loss of protein? You will develop overt proteinuria. You will see a lot of overt proteinuria in these patients. So for them we say we give ACE inhibitors or angiotensin receptors blocker. Okay, these drugs are given to prevent the overt proteinuria, which also is a problem in CKD. Also in these patients, type 2 DM patients, you also should give these SGLT2 inhibitors because they are known to decrease the progression of nephropathy. Okay, you should remember they're only given in type 2 DM and never in type 1 DM because this is an oral drug, and oral drugs are not allowed in type 1 DM. Now let's come back. So I was telling you that in decay there is dehydration because of the loss of glucose. What happens? A lot of osmotic diuresis develops. So this glucose will also drag water along with it, and you will develop osmotic diuresis. This will cause dehydration. Also, you will lose a lot of sodium potassium along with it. You will lose sodium, you will lose potassium, you will lose chloride, so you will lose electrolytes because of the diuretic effect. You will lose all these electrolytes along with it. Now the potassium that is there is low in the blood now because of the loss of potassium, but you will not see hypokalemia in these patients. So I am telling you that potassium is getting lost in the urine, but when you draw the blood of these patients, potassium level is normal. How is this possible? If I am telling you that potassium is getting lost in the urine because of the diuresis, it should be low in the blood, but the cells in our body, they are bags of potassium. Cells are bags of potassium. They will be transcellular shift of this potassium from cells into the blood. So what you see, normal levels of potassium in the blood, but the cells are deprived of potassium. That is why whenever you start insulin to these patients, what insulin will do, it will quickly take back the potassium inside the cell when you start the treatment in these patients, and this potassium will go inside the cell, that will result in hypokalemia. So insulin treatment will result in hypokalemia in these patients. So you should be very careful and correct potassium along with hyperglycemia. What will the blood picture? It will be a high anion gap metabolic acidosis. So you understand what is metabolic acidosis? What is a metabolic acidosis? Let me just tell you that whenever you have acids in our blood, like lactic acid, like ketone bodies are nothing but acid. Beta hydroxybutyric acid, acetate. What are they? They're acids, suppose. Beta hydroxybutyric acid, I'll write in short. Then acetoacetate, they are all acids. So these are acids, and because these are acid, so it will give you metabolic acidosis. Now, why it will be high anion gap? See, what is anion gap? It is measured cation minus measured anion. Okay, this is the main thing. I know there is a formula, but this is the main thing. Measured cation versus measured anion. Now what happens? What is anion gap? Anion gap is the unmeasured anion, right? So whatever is your unmeasured anion, that is your anion gap. Now, in this condition, in metabolic acidosis, you are having lot of acids. So what will acid do? Acid will give H plus. Suppose I have this acid, CC0H, acetic acid. This will become CCCO minus and H plus. So this H plus will be in your blood, and this H plus is the cause of acidosis. So this H plus is giving you acidosis, and what your body will do as fighting mechanism, the measured anion, in that measured anion we have two things, HCO3 minus and Cl minus. This HCO3 minus will be used up in fighting against this H plus. So what is happening? Your HCO3 minus is getting used in neutralizing the H plus that came from this acid. So what is happening as a result? So HCO3 minus is getting used up. Okay, so what should happen? Measured cation minus measured anion is the unmeasured anion. Unmeasured anion, that is your anion gap. Anion gap is nothing but anions. Which anion we haven't measured? What is the anion that we haven't calculated? That is anion gap. It is measured cation minus measured anions. Now in your measured anion, your HCO3 minus is going down, but your acid is high. Your acid is high. What is that acid? It is your lactic acid or acetic acid or beta hydroxybutyric acid, whatever is the cause of your acidosis. So your acid levels are high. And which one is more, HCO3 minus or acid? Here acid is more. That is why you are having acidosis. Your pH is less than 7.35. That is the definition of acidosis. Now it can be metabolic or it can be respiratory, whatever. But acidosis means pH is less than 7.35. So if you are having acidosis, that means you have more numbers of acid. So even if the HCO3 minus is less, your acid is more. And this acid is your unmeasured anion. And as a result, your anion gap will increase. So now what is the normal anion gap? Normal anion gap, what is the normal anion gap? It is 8 to 12. So what do we mean by high anion gap metabolic acidosis? It is when the anion gap is more than 12. More than 12. So here, because the acids are more, so your anion gap is increasing, because also because of the decrease in the number of bicarbonate. Okay, so suppose your measured cation was 140 and your measured anion was 130. What is the anion gap? 10. But because it is now 124, why it is 124? Because the HCO3 minus have been decreased. Why? Because they went on to fight against this H plus that came from the acid. So HCO3 minus इसके against fight करने चला गया, and in order to fight against that, he got sacrificed, and that is why the total anion level has gone down. So now what is the result? 140 minus 124. It is 16 now. So in high anion gap metabolic acidosis, your bicarbonate levels are getting low, and that is why you have a high anion gap metabolic acidosis. But This is in case of diabetic acidosis. But what happens in normal anion gap metabolic acidosis? The anion gap is between 8 to 12. Now it is not possible, right? If it is a metabolic acidosis, there is obviously some acid against which, and that is producing H plus. There is a metabolic acidosis and there is obviously an acid, and this acid must be producing H plus ions, and your body's bicarbonates must be fighting against this H plus, and they must be getting sacrificed. Then how come bicarbonate levels are not low? How come anion gap is still normal? Because anion gap is sodium minus chloride and bicarbonate. So your bicarbonate level is going down. If it is going down, it must go down because it is a metabolic acidosis. If it must go down, then how come you have a normal anion gap? Because anion gap is sodium minus chloride plus bicarbonate. The sodium is getting minus, so sodium minus chloride minus bicarbonate. How come it is still normal? It is because the chloride has gone up. So because bicarbonate has gone down, someone must have gone up. So it is chloride that has gone up, and as a result you have a normal anion gap. So that must be clear. So what is high anion gap metabolic acidosis? What is normal anion gap metabolic acidosis? Decay is one of the causes of hagma. I think you already know a mnemonic of it, mud piles. This is the cause of high anion gap metabolic acidosis. Methanol, uremia that develops in CKD, diabetic ketoacidosis, propylene glycol, isoniazid, lactic acid, ethylene glycol, salicylates, that is aspirin overdose. So M is methanol, U uremia, that is in CKD, D for DKA, P for propylene glycol, I for INH, isoniazide, L for lactic acid, E for ethylene glycol, and S for salicylate, that is your aspirin overdose. These are the causes. And nagma, which is also known as hyperchloremic metabolic acidosis, nagma, it is caused by conditions like diarrhea, which is loss of fluid from the GI tract. Then you have loss of fluids from the kidneys, like renal tubular acidosis. Remember, it is loss of bicarbonate through either GI tract or kidney, that is the cause of nagma, diarrhea or renal tubular acidosis. So DKA will give you high anion gap metabolic acidosis, that is clear. Next, we have understood the pathophysiology. Symptoms. We know the patient will have a fruity odor of breath due to the acetone. The person will have dehydration, that will lead to hypotension. So dehydration will lead to hypotension. Altered sensorium, which will lead to coma. Okay, so fruity odor of breath, dehydration, that will lead to hypotension, and altered sensorium. Kussmaul respiration, very important question. What is Kussmaul respiration? This is a form of respiration which is seen in almost any kind of metabolic acidosis. So the person is taking a deep as well as rapid breaths. So both deep breath and rapid breath, like this one, deep and rapid breathing. Deep, rapid, the term is labored. Deep, labored, rapid breathing, which is seen as a compensatory mechanism to metabolic acidosis, because by this deep, labored, rapid breathing, the person is washing away the carbon dioxide. Carbon dioxide is your acid. So by washing away CO2, the body is compensating for the metabolic acidosis. So there is a deep breathing, rapid breathing, and it's a regular breathing. The body attempts to blow off the CO2 via the lungs. Now this is a form of respiratory compensation. This is a form of respiratory compensation to the metabolic acidosis. Classically, it is seen with DKA, but even in uremic acidosis, which is seen in CKD, this may be seen. Lactic acidosis, all this. So it's a sign of severe metabolic. Whenever you have Kussmaul breathing, that is, it's a severe metabolic acidosis. What is the diagnostic criteria? So the diagnostic criteria is glucose levels in the blood more than 250 mg per dl, ketosis, that is presence of ketone bodies in blood, like you have the presence of beta hydroxybutyric acid, all of that, and your pH will be less than 7.35. Bicarbs will be low. How much low? It should be less than 18 milliequivalent per liter. Bicarb less than 18. pH should be less than 7.30. To diagnose DKA, they are saying that the pH should be less than 7.30. Ketone bodies must be present, especially beta hydroxybutyric acid. Presence of beta hydroxybutyric acid you can detect both in urine and serum, preferably serum. So first, glucose, it should be more than 250. So diabetes confirm हो गया. Ketoacidosis, for that ketone bodies must be present. Acidosis, we check the pH, arterial pH, it should be less than 7.30, and it is a high anion gap metabolic acidosis, so your carbonates will be low, less than 18. So bicarb less than 18. Chlorine levels will be normal, and it's a high anion gap metabolic acidosis, so your anion gap should be more than 12. So 5 things: glucose, diabetics, keto acidosis, ketone body, and acidosis pH checked, and it's a high anion gap metabolic acidosis, so anion gap has to be also checked, and bicarbonate should be also checked. So 5 things together, this is our diagnosis. Differentiated always from hyperosmolar hyperglycemic state, HHS, which is only with type 2 DM, and DKA is mainly seen with type 2, not type 2, sorry, type 1 DM. Okay, this is characterized by severe hyperglycemia. Your glucose levels will be more than 600 mg per dl. Because of this, you will have high serum osmolality, which will be more than 320 milliosmol per kg. Your pH will be again low. So pH will not be low, pH will be more than 7.3. It is not a acidosis, so pH will be more than 7.30. It may be 7.32, but it will be at least more than 7.30. Serum bicarbs will be more than 18 because it is not ketoacidosis. So anion gap will be normal because you don't have any metabolic acidosis. Ketone bodies will be absent. So see, you have to differentiate it from decay. For that you will check the bicarb. For that you will check the pH. So it is not ketoacidosis because you don't have ketone, you don't have low pH, you don't have low bicarb, and you don't have high anion gap. So you ruled out decay by checking ketone bodies. So there is no ketone body, there is no acidosis, there is no high anion gap because bicarbonate is normal and also anion gap is normal. So after ruling out decay, you just check the glucose and osmolarity levels. Glucose is very high, osmolarity is very high. Glucose more than 600, osmolality is more than 320 milliosmol per kg. So this is confirmed. Normal osmolality of a person is normally between the range of 275 to 295 milliosmol per kg, but in this it will be more than 320. Normal is this range. The management of decay is management. You have to correct three things: dehydration, hyperglycemia, and acidosis. And also you have to treat the stress, the underlying infection which triggered it. So first you do resuscitation, fluid resuscitation. So dehydration is the first step in correction. So for that, what you give NS, normal saline, 1 liter per hour. NS 1 liter per hour. So in 2 liters you will give in 2 hours you will give 2 liter of normal saline to this patient, because every hour you are giving 1 liter of saline. Then after 2 hours you check the serum sodium levels. So after 2 hours, after giving 2 liters of NS, you check the sodium level. Check whether it is normal or if it is elevated. If it is normal or if it is elevated, if it is normal or elevated, then only you switch from 0.9% NS, that is a normal saline, to half NS, that is 0.45% NS. So from normal NS you shift to half NS by checking the sodium level at the end of 2 hours, if it is normal or increased. If it is normal or excess, or elevated, only then you switch to this. Then what you do, you also, along with this switching, you now reduce the flow rate to 250 to 500 ml per hour. So first hour and the second hour you gave 1 liter of NS. So within 2 hours you gave 2 liters of NS. You check the sodium level at the end of 2 hours. Now you have to reduce the fluid dose. Okay, so now you have to bring it to 250 ml to 500 ml per hour. But what fluid I have to choose? Now this will be decided based on the sodium levels. If the sodium levels are normal or elevated, you switch to this half NS. If the sodium levels are still low, you continue with the 0.9% NS. But the dose has to be reduced, the flow rate has to be reduced to 250 or 500 ml per hour. So this is fluid correction. Next, you check the electrolyte levels. So in dehydration there is also dyselectrolytemia. Dehydration and dyselectrolytemia. So you have to correct both dehydration and dyselectrolytemia. Then you went on to correct the next thing, hyperglycemia, by giving insulin. What insulin you give? Obviously IV insulin you give, not subcutaneous insulin. So you give IV insulin and you start it after 1 hour. So first hour it is only dedicated to fluid. After 1 hour of fluid administration, then you give your IV insulin. Okay, this is remembered, clear? What is the dose? The dose, you have to give IV insulin at a dose of 0.1 unit per kg per hour. 0.1 unit per kg per hour. Read it 3 times, 4 times, 5 times. Keep it in your mind. 0.1 unit per kg per hour is the dose of IV insulin. But this is given only after 1 hour. This is to reduce both the glucose levels as well as the ketone levels which are causing the acidosis. So both hyperglycemic correction as well as reducing the ketone body levels. For them, to reduce the glucose level in the blood and also to reduce the ketone body levels in the blood, to reduce both glucose levels in the blood as well as ketone body levels in the blood, you give this IV insulin at this dose. Then you the blood glucose levels. So it was more than 250, right? Once it drops and it is now between the range of 200 to 250, preferably when it is now near 200, when the glucose level is now near 200, you reduce the infusion rate. sorry, you don't reduce the infusion rate, you continue with this infusion rate 0.1 unit per kg per hour. But once it becomes 200, you insulin along with insulin you also start to give 5% dextrose. 5% dextrose you should also give to the IV fluid. Matlab, in one bottle of NS which is containing 500 ml, you give one bottle of 5% dextrose, which is approximately how much? Approx 100 ml. You give 5% dextrose in this bottle of NS and you give. So insulin along with 5% dextrose once the glucose level becomes 200, because you don't want to develop sudden hypoglycemia. To prevent hypoglycemia from developing, you give this 5% dextrose and you slowly reduce the blood glucose level, not fast. Okay, your target should be to reduce the blood glucose level by 50 mg per dl per hour. So suppose the patient came at 12 o'clock and the blood glucose level is 300, you reduced it to 200. Okay, now you reduce it by 50 every hour, 150, then the next hour 100. Okay, so this is how you should reduce. Target is to reduce it by 50 mg per dl per hour, not fast. The moment you start controlling the glucose levels, ketone bodies starts to disappear. Electrolyte management. So fluid management we saw, and we were also checking the electrolyte levels. We corrected the glucose levels as well as ketone body levels. Along with that, we indirectly corrected the pH, but also you will correct the pH, but later on I'll tell you how to correct the pH. But first, electrolyte correction. So initially serum potassium may be normal or elevated. It may be normal or it may be elevated because of the acidosis. Due to acidosis, what happened? The potassium from inside the cells came to the extracellular space. Any kind of acidosis, potassium will come outside the cell. Once insulin therapy is initiated, potassium will shift from outside into the cell. So it is important to monitor the potassium levels. If potassium levels are less than 3.5, so it is a hypokalemia state, do not start insulin again. You have to start insulin after 1 hour of fluid administration. Also, after end of 1 hour of fluid administration, you have to check the potassium levels. If it is less than 3.5, don't start insulin. Give IV potassium. Okay, with fluids, and once the potassium level is corrected, then you start insulin. So you don't want to correct the hyperglycemia. Your target is to correct the dehydration and dyselectrolytemia. That is the target. Treat dehydration, treat dyselectrolytemia. Once they are corrected, or once you know that okay, they will not get affected, only then you treat hyperglycemia by insulin, and automatically ketone bodies will also get managed. If pH is very low, less than 6.9, then only serum bicarbonate is recommended. It is not recommended unless pH is less than 6.9. For severe acidosis, bicarbonate therapy is considered, but its use is controversial. So you corrected dehydration, you corrected dyselectrolytemia, you corrected hyperglycemia, indirectly you also corrected ketone bodies and acidosis. For acidosis, only if it is very low, you give serum bicarbonate. You have to check every hour. So hourly, you have to check urine output, because it is a state of dehydration. Check dyselectrolytemia. So check the serum electrolytes, and also you check the blood glucose, because you want to correct the hydration first, then electrolytes, and then blood glucose levels. Also along with blood glucose, you check for ketone bodies, and obviously you want to check the pH levels, right? Because you are correcting acidosis. So check the urine output, because you want to correct the dehydration and the dyselectrolytemia. Also check the blood glucose levels and the ketone body levels, and also check the pH levels. And ketone bodies you don't check every hourly. Ketone bodies you can check every 2 hourly, but that is not important. But urine output, electrolyte levels, these are must. pH, blood glucose levels, okay. Treat the stress. Whether it was infection like pneumonia, UTI, treat with antibiotics, okay, whatever is the cause. So I told you that the target to reduce the glucose level is 50 mg per dl per hour. This is the rate of reduction. Now you started with IV insulin. You started with IV insulin at a dose of 0.1 unit per kg per hour, and your glucose level is now near 200. So now you want to reduce it at the rate of 50 mg per dl per hour, right? But how? Initially you reduced with IV insulin. Now you switch to subcut insulin. So by giving subcutaneous insulin, you want to now reduce the glucose levels slowly. Okay. This is the management of TKA. Thank you.